to an acute sense, the difficulty of getting any kind of support system.
Yeah.
I belong to the Academy for Lifelong Learning at the University of Toronto, which represents about 400 seniors who are active learners.
Yep.
One of the main concerns people have is who's going to look after us when we can't do it anymore. And now the policy is stay at home, but there are no more facilities, and the expectation is you have family, neighbors, and friends. My friends are all getting frail.
Yeah. Well, you know, I mean, that's geez, you already know what's coming here in the slide deck.
So I hope you have some solutions.
Yeah, I do. Like save up, right? and make good with your. No, well, we're hoping for a little bit more than that, but you know, that's the typical solution in the society. Plan ahead, but it's tough to do. My mother's got Alzheimer's. She's doing fine. She's 92. But without checking her meds and going to the bank, she's gone. So we check her meds and go to the bank.
Is she in a long-term care facility?
No, she's living at home.
So she's living at your home or her home with you?
No, she's living at her home, and my sister and I care for her.
Yes.
Okay. Yeah.
So I'm in the same situation with my mother, but she's in a retirement home.
Yeah.
But my brother and I do all the stuff that needs to be done to make life run smoothly.
Good. Okay, we're going to show you some data on what people do, and maybe you can. And the gentleman in the middle.
Oh, hi. I'm Carlos Ruano. I'm a classmate of Patricia. We both at the PhD program in Information School, and in a previous life, I did a lot of lifelong learning issues. This is kind of part of the whole spectrum of how to work across the lifespan of various issues that interest me. So I didn't know that it existed until Trish talked to me about it. So I'm like, I would like to come more presentations to learn more about these issues.
Great.
I'm actually a student here as well.
Great.
I mean, I'm at the Faculty of Cognition, but I'm in the collaborative program. Right. So it collaborates with the Institute for Life, Person, Aging. So I brought Carlos and said, you're going to like this place. You really
recruited me.
Awesome work.
That's right.
We're on the air now?
Yes, we are, and I have a question from one of our people.
But do you mind if we
no, I don't mind.
Just a few more people say hello.
Hi, good afternoon. I'm Robin Kassam. I'm a police officer with York Regional Police, and I'm the senior safety officer in our personal safety unit. So we have a dedicated officer in York that my area of specialization is in seniors and working with seniors in our communities. We have a huge aging population in York Region.
No, for sure. Well, you know.
So I work collaboratively with the other police agencies and kind of work together and try to get our seniors out of crisis and situations like this arise. So I just felt that this was a great opportunity to come and learn. Thank you.
No, thank you. Where did that go?
So I'm Latrina. I'm a PhD student over at the Rehab Science Department, and I'm doing my research on implementing factors that influence the implementation of family caregiver programs into the Ontario stroke system. So this is very interesting.
Great.
My name is Ronnie. I'm a former UT staff many years ago. I'm UT staff spouse. I was caregiver for my mother for almost 7 years. Fortunately, she ended her life at Kensington Gardens, which is a wonderful place. And it looks like I may start to be a caregiver for another family member who are over the past year or so.
Well, welcome.
Thank you.
I'm Amy Rivera. I'm PhD candidate at IADL.
Oh.
Studying, my research topic is on rising life expectancies.
I didn't catch the last part.
Rising life expectancies.
Ah. Yeah, that's a good thing, eh? Well, maybe.
Yeah. My name is Esther. I'm a social worker in the geriatric education program at Cambridge.
Oh, excellent. You know that place too?
Hi, my name is Nikki Barton. I'm an RN that provides private help in the community, basically linking patients or rather clients with services in the community that they don't even know about. service is sliding scale, so I'm not part of an agency. I do it according to income. That's for 6 months of the year, and for 6 months of the year I support and take care of my mother in the UK.
Gail Houston, a semi-retired nurse, and I have both a personal and professional interest in this topic.
Great. Well, thank you. So, so many of the things you've said will hopefully resonate a little bit. And it's, I've never had the police here in that sort of situation before. Usually, usually we're trying to get away.
Most people don't like this.
No, but you know, you see, I'm really glad you're sitting there, because when you start to think about this, gee, you know, there's a lot of stuff that goes into maintaining yourself at home and safely and everything else. And so we used to think about this just in terms of health care, you know, which we still do. But there's a lot of agencies, and if you think about what keeps you safe and active every day, boy, there's quite a range of things that you have to connect with. And the job you're doing is really key, because this is one of the key reasons why caregivers burn out. If stuff is there, you don't know where or who to phone anyways. Okay, and look at me. I mean, I know a little bit. I know most of the agencies around here, but I'll tell you what. You just throw up your hands some days, and when they phone you up and say, we have a bed for your mother, and if you don't take it now or in 3 days, you're not getting one for another year and a half. You roll the dice that day, right? And you hope you got enough telephone numbers to keep everybody safe in here.
And it changes all the time. Exactly. Things change constantly.
And I have to say, so this is a bit of an aside, sorry everybody, but there's my mother goes to church down the street at St. Patrick's every Wednesday. This is the most important thing in her life, and in fact, we get a personal support worker to take her to church on Saturdays, and so I pick her up. And one day, I don't know, she left. Couldn't find her, looked all over the place, not in the bathroom, checked out the restaurants, so I go, oh my God. So I'm going up the street, and I see a policeman coming down the thing, and I actually did a U-turn right in front of them, right? Okay, so the guy goes, what are you doing? And I go, my mother's got Alzheimer's, I don't know where she is, can I park here, please? And he says, yeah, because if you don't get her like in the next 5 minutes, then we have to go find her. And it's not going to be good. So go find her. Anyways, I found her. She decided she wanted to go eat, and she was in one of the restaurants. Well, I'll tell you what, that scared the you-know-what out of me, because I wouldn't know what to do after that. Okay, so look, we've already got in here, like, why informal caregivers? And what we know is, you know, the system isn't even there for my mom, except when she has a healthcare problem. And she gets a little bit of home care, but not very much. And so what we know is this is a crucial role that informal caregivers, mostly women, mostly unpaid, are picking up the work here. That was historical. We don't know if that's going to be the future. Maybe the men are going to do a bit more, hopefully, but it looks more like everybody's going to do a little less. Okay, both males and females. So if you're thinking that 80% of what happens out there is provided free by informal caregivers, and you start to play with that number, even shift that a few points, what happens? Well, obviously it goes over to the formal care system somehow. Somebody picks this thing up. And what we know is when it gets there, it becomes real expensive. And often inappropriate for the people it's serving. I mean, anybody ever sat in an emergency department? Oh, not a good place to be, right? Yeah, you've been there, right? Well, nobody wants to go to the emergency department, so this sense that everybody's going to emergency, well, not if they can avoid it, or not if they know there's some other alternative, but in many places there isn't. So, the other thing I want to say is we're talking a lot about older people right now, but I just want to remind everyone there's other groups too. For instance, one of the things you're going to see is there's many more kids who would have died at birth who are now living. And they're not living for a couple of months anymore, they're living into adulthood. We haven't even been there. We don't have anything for them, okay? Nothing. And also people with disabilities are aging, they're living. So in addition to the spinal cord injuries, they're now getting everything that comes with aging, right? And we don't have any experience with that. This never happened. So the good news about medical technology is that people live longer. The bad news is it's all medical. We haven't really thought about anything, all the rest of the things that either help you stay well or stay active or all the rest of the stuff. So, why Caregivers Now? if you read Ontario's action plan for healthcare, it starts with two things. It talks about the twin imperatives of an aging population, which is wrong, by the way. It's not the aging population, it's growing need, and I'm going to talk about that in a second. It's not aging population. But the second thing is the fact that the system is under massive strain. So all the budgets have been flatlined except for healthcare, which is supposed to grow at 2 to 3%. But that's a lot of money still, particularly when you don't have any. So anything that impacts on the growth of that number is really something that you want to be thinking about. Now, fact check, just before you think I believe this. The aging population in and of itself is not the thing that's driving healthcare costs. And so if you look at these numbers, for those of you on the web as well, you can see this 3.6 number at the top. So what is that? It just means that there's a lot more people getting paid a lot more money to do a lot more things. Not just for the aging population, for everyone. In fact, if you look at the US as well, if you're looking at why things are increasing, because it looks like utilization for everybody is being driven up, including a lot of stuff that doesn't work at all and is in fact counterproductive. So you may have also read the CIHI report that says 35% of the drugs, sorry, I'm making that up, it's between 30 and 35% of the drugs that are prescribed to older people are not only useless, they're actually counterproductive. They're the things that cause the hip fractures, right? So we've got a lot of utilization in there. Some of it, hopefully, is good. Some of it's clear out bad. And a lot of the utilization, a lot of the increases we're seeing is not because of aging population. That's about 1% of it. Oh, sorry, this is population growth. This is aging population, 0.64%. This is because the system is trying to take on a lot of stuff now, and a lot of stuff, much of which is a waste of time or counterproductive. The other thing I want to say is that a lot of this stuff, yeah, go ahead.
You talk about the mass, the salary mass on the 3.6%. I'm not sure what.
Yeah, so professional fees are going up. People get paid. So, for instance, one of the fastest rising things is doctors' incomes in Ontario.
Now you tell me.
Well, you're talking if you're a doctor, you're not talking if you're a funder. And that's one of the issues. So primary care reform, you may know that we've been engaged in that. They brought in different fee models. What the fee models have done mostly is increase people's incomes. But nurses want to be paid, and professionals want to be paid, and social workers want to be paid, and everybody wants to be paid. So this is paying people, which is most of what the healthcare system does, by the way.
Sure.
Right.
Thank you.
The other thing that's really important now, I'm showing this to the Chinese visitors as well. We've seen a massive shift from acute care, which is still important, right? I mean, if you've got cancer or something else, that's important. But it's not one of the top drivers of illness and wellness any longer. We've seen a massive shift to chronic illness, which is not cured. So we've got a system that does one-offs that cures you. Well, it doesn't even cure you, it cures your eyeball. It cures your hip. It cures your bladder. It cures your spleen. Right? I mean, the fact that you happen to be attached to it is neither here nor there. So we've got a system that's really, really good at that. And if you need a hip transplant, you know, it's a lot better than it was 15 years ago. And we're doing, of course, we're doing a lot more, and you have to ask yourself the question if maybe like exercise would have been a good idea. But if you look at this, everything that's on this is, look up this website, by the way, the Global Burden of Disease. Really great. They ran around the whole entire world, and they started to see what drives population health. And hardly anything to do with acute illness anymore. All of the communicable diseases have pretty much been wiped out. Not wiped out, you know, some people still get them. And it turns out that some things are coming back because people, you know, the herd immunity is dropping on. But mostly we're talking about dietary risks. So in emerging countries, it's lack of food. In developed countries, it's too much food. And it's the wrong food. Anybody read the Star today about those 6 chicken wings? Okay, I love it. They always have that thing like, here's what you ate for lunch and here's what was in it. Okay, 6 chicken wings now has enough calories for an entire day and more than your whole entire. Whoa. Okay, don't eat that. The second thing, which is totally deal with, smoking, right? Well, that's an easy one. Just stop smoking, everyone. Well, but that's an easy one, and the Chinese are aware of this too. Lots of people smoke. And then the third one is, you know, we're among the fattest people in the world now, and that leads to the other things, you know, high blood pressure and glucose and cholesterol and Well, alcohol use, you see, I was hoping that was lower on the list, because that's, some of these I do like. But, and occupational risks, I think that going to work actually is a bad thing. But never mind. So the point is here that we've got a system that's all set up based on a series of assumptions, one of which that the other stuff that's not acute care, somebody else is going to pick this up. Even as we know that this isn't what's driving people's health and well-being anymore. And by the way, they look the same in most of the countries. When I was down in Mexico, I said, okay, so you guys are now the second fattest guys on the planet. And they actually, the guy put up his hand and he says, no, we're Mexicans, we're number one. Way to go, guys, that was great. You see, not only do the Mexicans are funny, they know they're funny. Or at least the guys I know. And then we got the, all of these things that are gonna like wipe us out. So the Alzheimer's Society, who we work with, and they're excellent. But to keep everybody's attention, they've got the rising tide. Yet another epidemic going to wipe you out. Well, my mother's got advanced Alzheimer's, and she does pretty well. She doesn't know what day it is. If you told her to take her meds, she wouldn't know what you're talking about. And she goes, why do I need meds? When the PSW, why do I need a person? Because you're not coming back if we send you out there. But a lot of dementia, is simple cueing as well, right? People aren't sick. They can function. They can't remember. So what? She can't remember what day it is. Big deal. I don't even want to remember what day it is a lot of times. In fact, you see, the problem is when it starts to hit you, it wipes out the stuff you want to remember and leaves the stuff you don't.
Or when you forget to turn off the burner on the stove and the burner cover is still on it.
That's why my mother's stove doesn't have any fuses in it.
Those are some of the top calls that we see for service from police, is emotionally disturbed.
Sorry to interrupt.
No, but you're dead on. Okay,
It shows what lack of memory has, the day-to-day implications are just fine.
But think about it. Okay, we leave the stove on. You don't burn down the house. Okay, but you get the smoke alarm going. Who comes? The police come, which is very expensive. The first responders come, it's very expensive. They look at this old person's and they think, oh, gee, maybe something's wrong with her. They go and do an assessment. Uh-oh, in the emergency department, boom. Then you're in there because something else is wrong with you too. When my Uncle Rocco was 101, he went into hospital because I don't know why he went there. He was in supportive housing. And, they go, oh, did you know your uncle has heart arrhythmia? Yeah, but does he have a heartbeat? That's what he wants to know. Heart arrhythmia. Are you kidding? And they brought him in because of that. And he sat there, and he was cool to the day he died, talking about derivatives and stock funds and everything else. He said, you gotta let me out of here. I don't like it here. There's everybody screaming. The lights are on 24 hours a day. It's like the CIA, mind experiments. Let me out of here. And they go, no, it's not safe out there. He says, not safe in here. Okay, and if you don't let me out, I'm going on a hunger strike, and I will be on the front page of the paper. They let him out. And so, but my mother wouldn't do that. In fact, she'd get very confused. So there is an impact here. But the question is, what could you do which is non-medical? And it turns out a lot of stuff. See, this rising tide is both a demographic thing, but the cost is what you do about it. You have a lot of choices there. So maybe $872 billion. If you're doing a campaign that says, quite frankly, give us money to support Alzheimer's, you're going to make the number as big as possible. I think it also leads into the doom scenario, which says the system doesn't work anymore, let's go the American way. Everybody get what they pay for. So, and we do know that the caregivers are picking up the pieces though. Okay, so demands are getting more complex. System is doing some stuff out there. And somehow we're expecting these guys to pick it up. And what we do know is that some of the caregivers aren't doing so well anymore. And if, many caregivers spend 10 hours a week or less, but that's a day at work. But a lot of them are spending, 3 or 4 days. This is a full-time job. Okay, so when you get to that part of what we're finding, and Allie's going to talk about that, is that people are getting stressed out, not just because of the needs of people. I want to get that off the table, okay? Some of it has to do with my mother's needs, but a lot of it has to do with trying to maneuver the system. What comes next? That causes you immense stress, okay? You don't know what to do, and they give you the telephone call that says your mother's going in unless you have plan B. Roll the dice. Whoa, that's pretty stressful. So what we're finding is that the caregiving is in decline. Part of that is because nobody's having so many kids anymore, but also because women's role is changing. In Japan, you know, it's funny, I got up and I said, you know, I think you should consider caregivers because you don't have very many and everybody's living here till 104. And they actually, I got a really weird response back from the audience and they said, we don't tip here. So people have been to Japan. Any place you go to a restaurant and everything else, there's no tip. Service society. And you shouldn't pay somebody to do what they're supposed to do anyways. So therefore, forget the caregiver stuff. It just doesn't work. Now, the women in the audience didn't think that was such a good response. But the guys sure as hell did. So part of this has to do with people, but a lot of it has to do with the system that you set up, which doesn't do a very good job at responding to this and leaves you, you know, out there, figure it out for yourself. And then only when things get to the crisis stage will we pick you up in the emergency department. So this has real costs. This isn't just, you know, somebody should do it. Across the OECD, they're now estimating that if this continues, you're going to increase system costs by between 5 and 35%, and that will blow them. Nobody can do this one. We're going up by 2% this year. You hit a number around 10%. You know what's going to happen. That's going to be it for the publicly funded system. This is some numbers from CIHI, the Canadian Institute for Health Information. What it says, if we continue to do business as usual, responding to everything after the fact, look at what happens here. And Japan's the worst, okay, because they have, they're actually good. They're putting in infrastructure. So this looks worse than it is. But if you just do what you're doing now, your costs, you say, well, we're only going to do this, but this is going to be hard to control. And so costs are really going to increase. This doesn't even take into consideration if the caregivers drop out. So we know what we want to do. We want to transform the system. Everybody's been through this one 30 times in Ontario over the past 30 years. And we want to think ahead, and we want to do this stuff, and we want to get past the silos, and we want to go to chronic care and patient. Don't see much about caregivers on here, right? And then the senior strategy, we have that too. And there's caregivers around there someplace, right? They're mentioned.
They are.
Okay, but the point is, I'm saying that this is the key to this system, and well, they're there someplace, but I can't find it. I know I've seen it in here. And this is unfair because there is a paragraph in the report. There is a paragraph in the report. But look, we know what we want to do, right? This is what we want to do, and the caregivers should be in there too. Now here's what we're doing. These are actual data from the OHA, the Ontario Hospital Association website. Do you know what an ALC bed is? Alternative level of care, right? So basically, this is the total waste of our time and our money and the people in these beds. It's beds that are occupied in hospitals by people who shouldn't be there because you cannot put them anyplace else. So look, this is 2007. We were at 18% of the beds in Ontario. Total, throw the money down the drain. But worse than that, the people in those beds get worse every day. Okay, so every day an older person sitting in an acute care bed after the surgery or whatever is finished, 5%, they lose 5% of their capacity. All right? Let's go for 2-3 weeks. You're toasted. So by the time you get out of here, you can't go home anymore. So look, we throw in billions of dollars, all the wait time strategy, everything else, and now after, what, 6 years, we've got it down to 14.1%. Billions of dollars. In fact, I would argue you've totally failed because you're waiting till people get in the beds and then you're saying, we'll see if we can put them someplace. What a dumb idea. Particularly, no, but it really is a dumb idea because people get worse when they're in those beds. So we talked about the emerge. How about ICU? Anybody been in ICU? 24 hours a day, the bells are going, everybody's screaming, the police are in, everybody's in. Whoa, this is like from a horror story? Okay, so if you got dementia sitting in the bed, you got delirium before you walk out of there. Okay, so this isn't good. So we're willing to throw away 15% of everything we spend on a hospital bed. And this seems like a good deal, yeah?
Just with the ALC beds, I can only speak about CAMH, but there has been a lot of push towards emptying the ALC beds. the problem. There's a lot of family issues that come about as well
Sure.
that prevent placement. So it's not so.
No, it's not cut and
The,
dried.
the
Of course, I'm
households
making.
don't want those people on those beds, that's for sure.
No.
Well, okay, so I have to say, with my mother, when she went in, recently she had, I don't even know why she went in, but the doctor sort of panicked and said, well, she could have some respiratory things, send her in there. And so they stick her in a bed, you know, we all have to count up and you say, why am I here? Why can't I go home? I don't know. So the first thing they do is, even though she has a virus, they stick her in antibiotics, which all that does is weaken her and make her more susceptible to everything else. So she stayed in that bed for 4 days, and then they phone me up and say, you got to get her out of here. I go, get her out of here to where? What are you going to do? And they say, well, nothing. Take her home. And I go, well, just a second here. You're telling me she's ill, and now we're going to send her home. Then what happens? Somebody come and visit her? Somebody come and, no, sorry, she's not ill anymore. Okay. And then they explain to you why it's an unsafe place for her to be. Right on. But listen, I'm sorry, but I'm not taking her until you have some sort of plan here. So I'm one of the resistors. Okay, I know I'd like her out of there. I don't think she should have been there. But listen, I'm not, like, what are you doing for a living here? Okay, I'm just going to take her home and she's going to, like, expire in her bed? Okay, so no plan, get her out of here. That's the plan. So they go, what kind of car do you have? And I go, a Jeep. Oh, they say it's probably tough getting into a Jeep. What if we gave her an ambulance? Would that get her out of here faster? No, it's not going to get her out of here faster until you tell me what happens next. So I'm one of the resistors, not because I think that's a good place, but because actually I think the system has some sort of responsibility, and that's not you.
Yeah. It's also not families, it's also long-term care facilities as well. They don't want to.
They don't take them?
They can't manage.
If you got a behavioral issue, if you're going to push or maybe kill somebody, they're not even taking you. So think about that.
Crisis placement is taking up most of the beds, though.
Yeah.
I mean, that's the reality, right? There's more crisis cases out there.
Yeah,
People that are waiting a long time.
Yeah, by the time, well, there's no more beds, and we're not having any more beds. So what do we do now? Okay, so let me.
Back out.
Yeah,
That's good.
that's why. You guys have changed your jobs now. It used to be apprehending criminals, now it's apprehending demented people. Okay, here's another piece of data, also from the OHA website, just to show you I'm not making it up. What it shows you at the same time, this is it. So this line is, can you imagine this? They bother to put this on the graph. This is for people waiting in an ALC bed to go home with nothing. Okay, you think that should be 0, but it isn't. Now, but this is the one. This is waiting to go home with home care. And what's happening at the same time as those ALC things are not dropping off, it's going straight through the roof. There isn't any service out there. So this cycle isn't getting better. In fact, this suggests it's actually getting worse at a fairly quick pace. No good. This is OHA stuff. Okay, so this isn't like some communist thing. The other thing we're seeing with the CCACs, the Community Care Access Centers, that provide some home care, and particularly now after the fact care, this is level of need, okay? And this is a timeline from December 2010 to April 2012. So it's sort of recent data. And what you're seeing is that all the preventive stuff is dropping out. All the stuff that could happen before you go in is washing out. All the resources now are going to after the fact stuff. And even with that other number I showed you is going through the roof because it doesn't match anything. So we've made a bet here. And this is Central CCAC, okay, north of the city. Central is putting all its money into post-acute, not because they want to, because LHIN told them to. They're wiping out programs like medication checks. They know this isn't any good. They know it's going to happen, right? And it's going to get worse, but that's what the politicians tell them. They get them out of the beds because this is the big problem. Okay, we haven't hit the caregivers thing yet. So, but think about this now. What happens to the caregivers in all of this? Okay, well on the front end, you know, you're doing your best to keep them out. And on the back end, you better be prepared to pick them up, you know, and get them out. So this cycle is intensifying because the caregivers are doing the stuff that's getting stripped out of the system. So you're expecting them to do the same thing. No, but you're also increasing the level of difficulty at the same time. Oh. So, you know, you're looking and thinking, wow, this is the doom scenario, eh? Like, how could this get better? Let me show you some data from stuff that we did. We went around the province looking at people waiting for long-term care, and we asked a simple question: why is it that some people look like this, go in, and other people's look exactly the same way, stay out? Because you think that it's just it's getting triaged up. The people going to long-term care really have higher levels of need. So this is 2-3 years, but it's still a lot of people out there. So we looked, for instance, to find out in some regions of Ontario, pretty low level of need. You're going in. In other regions, it's actually relatively high. So what's going on? One of the things we thought of that this was people with Alzheimer's, so they can't deal with them, so they got to go in. Well, but we found when we started looking, this is actual assessment data for actual people, right? It's not a survey or something else, or here's what I think. And we found that, geez, there's a lot of people in some places. This is the Northwest that are totally intact. Like, what are they waiting for long-term? Oh, it must be something else. They're incontinent. So then we go and find out if they're incontinent, and we find out in places like the Northwest, gee, they're not incontinent. In fact, they can do everything by themselves. Like, by themselves. Well, what's the answer, folks?
Wrong.
Huh?
Wrong people are going.
Well, but why are they going in?
Is it their coordinators are assessing their eligibility, caregivers are making the decisions?
Yeah, okay, but why? But why would a coordinator who's not there to put people in? I mean, they really, the coordinators themselves are not trying to stick anybody anywhere.
The beds are available.
Are you?
No, not necessarily. This is just to get on the wait list. We don't know how many people. I haven't shown you who actually converts.
Yeah.
But they've been assessed. Their needs are high enough now. They stick them on a wait list.
Maybe it takes so long.
Sometimes it does. Sometimes it doesn't. This turned out to be the killer. It's the IADL stuff. Okay, so particularly in the Northwest, we asked the question why. It's because there's no infrastructure in the Northwest beyond Thunder Bay. So if you've got a problem like a medications problem, and you've got Alzheimer's, and you live any place past the city limits here, what's the alternative? Nothing. So part of it has to do with people's needs, but the second one has to do with the capacity of the system to respond to those needs where they live before things get worse. Now, when they get to the emergency room, this isn't a joke like they're throwing them in because they don't need it. No, they need it when they get there. But the question is, could you have done the medication check and they could have stayed at home? And the answer for these guys is, yeah, it looks like this is the point. And this was, so you can see here, never mind, I said, I'm going to get complicated again, but I don't have to. The second thing, particularly if you live in places like the Northwest, if you've got no formal service infrastructure and you don't have a caregiver, that's that. Break a hangnail, you're going into a hospital or you're going to long-term care. That's it. Very simple, right? So where do caregivers come in? If you don't have a caregiver, or the caregivers drop out through the rest of the system, like you start to look like the Northwest. And let me tell you, the Northwest are very nice people. Okay, these aren't some miserable people who just want to go institutionalize it. They're trying their best, but they've got this massive landmass with no population density and basically no infrastructure. So they're doing the best they can, and the caregivers and everybody else is doing the best they can, given your options, which are pretty much nil past the city limits. So I'm going to turn over to Allie now.
Thanks, Paul. So I was fortunate enough to have access to all of the balance of care data that we have conducted over the past few years. And I really wanted to take a look at what was going on with the informal caregivers. Now, we were using the resident assessment instrument for home care data, so there's not that much information on informal caregivers, but there was enough to kind of get an idea about who they are, what they provide, and start to kind of figure out if there's any implications in terms of we're relying on them to provide that 80% care. Are we going to be able to continue to rely on that? And if not, what happens? We revert to the default options of more costly care that are not pleasant for the individual either. So who are the caregivers? What we see here is that they're basically children followed by spousal caregivers. So we are really relying heavily on those children and those spouses to provide that care. And there can be some problematics here, especially when we start to consider children who might be attempting to work with the sandwich generation, so they have their own children, they're caring for their aging parents. But also, if it is a woman, now they're increasingly involved in the workplace. So how does that further complicate this trend? And the implications for not only that individual, but the system once they start to drop out. So, and beyond that, let's consider some population trends that might actually impact the availability of informal caregivers to continue to provide this type of care. We have ethno-racial population trends. So there are currently multi-generational households that actually allow informal caregivers to kind of share the brunt of care. But this trend's shifting, where generational differences and changes in filial piety are actually impacting on who's responsible to provide this care now and who are we actually relying on to provide that care. So these housing arrangements are actually shifting. So what type of implications might come from that? Also, children. Lower birth rates, as Paul was mentioning earlier. There's generational differences in the role of the woman. And there's the reallocation trend. So now children are moving from rural locations to city centers for employment. Beyond that, our parents are now retiring and they're moving to rural settings to have their nice retirement life, right? So what are the implications of those types of shifting trends? So likely relying on children is probably not our best option. And then spousal caregivers, we can just kind of jump to the idea of the increasing divorce rate and what that might look like and how we rely on them. So, do caregivers live with their client? Well, not really. So less than 50% of people on the long-term care waitlist actually have a caregiver living with them. Central and Central West do demonstrate an interesting trend here, where more than 50% of informal caregivers live there, and just over 20% actually of the secondary informal caregivers live there. May speak to the diverse population of these two regions, where they're may be more likely to have the multi-generational households and children living with parents. And then obviously likely having both caregivers under the same roof. But less than 50% of caregivers are actually living in the home. So often with the current trends that Paul was discussing, in order to return home, you really need that informal caregiver support. And if it's not there, what happens? We revert to more costly and often less appropriate types of care. So this slide here is really showing us the type of care that informal caregivers are providing. Most are providing emotional and support and advice. Most are providing IADL care, which, as Paul identified, is a really important component of home and community care in terms of maintaining people living in their environments. And some caregivers are providing ADL care, but it's not the most sexy type of care that people want to provide, so people tend to steer away from that. So now let's think about the trend to focus on IADLs or the need to focus on IADL care. So in order for people to remain at home, this form of care is critical. So the system is increasingly pulling back from this type of support also. So we have two imperatives happening at the same time, and the increasing demand. There has to be then the increasing demand on the informal caregiver in terms of being able to provide this type of support to our aging population. So informal caregivers are providing a significant portion of care, and they're essentially spending enough time, like equivalent to a part-time job. So they're not spending no time, that's for sure. And we can see that there are signs of distress among the informal caregiver population. It's not the majority of caregivers, but it's still a disconcerting amount. So 13% of all informal caregivers providing care to persons on the long-term care waitlist are actually unable to continue to provide care, which is usually a response to an ailing health condition. Could be attributed to the informal caregiving role, but it also could be a pre-existing condition. And 17% of those caregivers actually have been identified as experiencing some form of feeling of distress. So again, it's not the majority, but it's still an alarming amount. And we have to remember that it's not just the needs of the people that are causing this distress. When we look at the Northwest here, as Paul was previously alluding to, it's likely also attributed by the availability of certain system supports or lack thereof, and being able to access them, knowing where they are and how to get those supports. So on average, 50% of informal caregivers are unwilling or unable to increase the amount of time that they currently provide spending advice and emotional support to their loved ones. Although most of them are providing that, so that's nice. And here we see that on average 68% of informal caregivers are actually unwilling or unable to increase the amount of time spent providing ADL, so the personal care. And we see that approximately 58% of informal caregivers are unwilling or unable to provide more time spent on IADL care. Again, alarming considering that this is the type of care that's really required essentially to keep people at home. So overall, the majority of informal caregivers are unwilling or unable to continue to provide care. That's essentially what we're getting out of this. So caregivers are already showing signs of distress. So what are the implications of then relying on them to continue to provide this care? And essentially, we're expecting them to provide more. Consider that 58% of informal caregivers across Ontario are actually unwilling or unable, again, to increase the amount of time spent on that IADL care. 13% of caregivers in the 8 regions that we could identify are unable to continue to provide care, usually due to ailing health. And 17% actually experience feelings of distress. So they are providing that 80% of care. And with the policy focus being so heavily on the ALC issues and acute care clients, and the shifting site of care without really building that community capacity, meaning that we are essentially requiring more time provided by that informal caregiver. And then again, the implications on the system essentially and the informal caregiver and their networks when we start to consider all of those trends. So what are we doing? We're responding by caring for caregivers. So we do have, I'm missing my notes. We are responding by implementing a variety of different supports. But we're not really always responding in the same way. It's really variable. Different people are getting different things at different times, and the way that we're actually providing the supports actually varies quite significantly as well. So we're supporting them with many what I call simple one-off interventions. So we'll see things like indirect services. So as an example, that might be congregate dining, where it's really aimed at the care recipient, but the informal caregiver definitely does benefit one way or another. They might be able to have that time to go shopping, maybe get a manicure. That would be nice. Then there's these direct services that we're using to support them. So we could probably use an example like counseling or peer support groups. And then also the economic benefits that we're starting to see increasing amounts of in terms of pension credits, work leave arrangements, etc. But there's really no coherent policy response. It's very, very variable. There's a lack of consistency. So the application of these supports does vary. So for example, a care leave arrangement, which is actually available in many OECD countries, differs in length, the amount of compensation, the allocation mechanism in which they are using to provide that type of care, so care allowance, tax exemptions, what that might actually look like on the ground. And then also, on top of all of that, eligibility varies. So the criteria may actually involve combinations of income or needs tests. You might have to live with your loved one rather than be a live-out caregiver, which also can bring many complications. And you might even have to provide a minimum amount of hours in that caregiving role in order to receive the support. So while there is growing consensus in principle around the need to support these informal caregivers, there's actually very little consistency across and actually even within jurisdictions in terms of how we should actually do this in practice and what this should actually look like on the ground. So, the argument to do this essentially is falling because there's no evidence. But the evidence isn't necessarily there because there's a lack of consistency across what we're doing to provide these caregivers, and it's essentially very difficult to gather outcome measures to support why we should be doing these types of mechanisms. So what are we going to do about it? Really, there's no simple response. It's very complicated. It needs to be actually more complicated than using our just one-off simple interventions that I'm suggesting. We need to start to reconceptualize what the what the proper approach would be to support these networks of people. There's a need to redefine what the unit of care might look like in the home and community care setting. Informal caregivers are a very crucial component to the sustainability of this sector, so there really should be a push towards ensuring that they're actually able to continue in that role for various reasons. And we first need to decide what essentially we are expecting not only the formal system to provide, but what we expect informal caregivers to provide as a result. So asking questions like, is it reasonable to assume that informal caregivers will be able to continue to provide that 80%, or essentially ask them to provide more? And given, again, the trends that we discussed previously, it might be risky to actually start to assume those sorts of things, even though currently, business as usual, we are still assuming that. So to ensure sustainability of the informal network, we really need to start to improve our understanding about how best to support these networks of people. Thinking beyond health to health promotion, and moving beyond individual units to understanding that healthcare and social networks are actually an intertwined unit, and that this interconnectedness is only going to increase as the mainstream system continues to pull out. So we have two examples of innovative initiatives that have been implemented in the Toronto Central Local Health Integration Network. They really are expanding the way we start to consider the unit of care and the way we conceptualize healthcare, leading us to think beyond just the caregiver and consider a system of care supporting the context around these individuals. It's a really great starting point. So the first initiative supports caregivers of children with medical complexity who have essentially been discharged from hospital with very high levels of need. So, and often a result of life-threatening illnesses like cancer, coronary heart disease, muscular dystrophy, cystic fibrosis, etc. And the second initiative is aimed at supporting informal caregivers of high-needs older adults who are essentially at risk of hospitalization and or residential long-term care placement. And they often have chronic illnesses and conditions including, for example, dementia. So the key features of these initiatives, it's really interesting. They're taking a really unique approach. Now they're starting to consider not only the client, but they're starting to consider the caregiver as well as like a unit of care that all need to be considered together. So it's a really interesting, unique approach that's really developing the way we should start to think about how we support people. So it's we start with a key worker or a case manager that engages the caregivers in a really dynamic process of problem solving. So they sit down together, they engage in a conversation about, what do you think you need to survive till tomorrow? What do you think you need to survive next week? What do you think you need, etc. The conversation goes on. And then what really happens is they're able to negotiate as a team different types of supports that might best suit this network of care. So different things happen from this. We get family care, household expenses, we can start to pay for unfunded equipment that we really actually need in order to maintain ourselves in the community. And also we can start to think about different recreational programming or even health promotion activities that might self-care. Now I feel better and I can go home and really care for my loved one. But obviously, improving this basket of services and bringing it beyond what the traditional basket of services might look like, it does pose crucial questions about what do we expect caregivers to do for themselves, essentially. If everything's in, are some things out? What isn't okay to provide? When do we draw the line? Do we draw the line? And then, what's actually needed to sustain these networks of care versus what's just nice? So it really starts to, again, it's a challenging, complex way about supporting networks of care, but I think it's really the way we should be going. So we've got lots of lessons learned and lots of aha moments throughout the evaluation of these two initiatives. And really we found strong support for the initiatives among all stakeholders involved. So there were caregivers who really started to express feelings in terms of them being less nervous, more confident to provide that care, and more confident about knowing where to go, and confident that when they go there, they'll actually get the help they need, which is huge. And caregivers and key workers also saw it as a powerful tool for engaging and building trust, identifying and addressing problems, and then avoiding and managing crisis. Case managers also felt that at least in some instances, long-term care placement may have actually been avoided, and if not avoided, definitely deferred. So it depends, what chunk of time is a significant portion of time. And as a result, caregivers definitely felt that they knew where to find help when they needed it. And then beyond that, providers started to observe that not only are we connecting networks of informal caregivers and professionals, but we're actually starting to build connections between different professionals, and it's benefiting more than just the individual caregiver, more than just the individual care recipient. It's actually starting to integrate networks of professionals, informal caregivers, and really involving everyone in a dynamic discussion that hasn't really happened yet. So it's very fascinating. So these initiatives have essentially reconceptualized the idea of the unit of care, moving from the traditional medical model approach of individuals or individual body parts, as Paul mentioned earlier, hips, knees, eyes, just to really understanding that without considering the context that someone's living within, the individual system would be unsustainable. So now that's why we really need to start adapting and reconceptualizing what healthcare and health systems means and what it should look like, just for its sustainability. So we started to transform what the traditional basket of services would look like, and it's now more flexible. We can adapt to the changing needs of the networks of care. We're moving from a fixed list of what's in to combinations of services and supports that are identified through a dynamic, engaging process, which was called problem-solving therapy. So we're beginning to redefine the relationship between formal and informal care, with informal caregivers becoming active participants in decision-making, but feeling really supported throughout that whole process. So we term this supported self-management, which is essentially when you start to think of our high-risk population that we are engaging, considering they're part of the reason that we consider them high risk is because they're having a really hard time managing our formal, essentially non-systems of care. So again, we're really starting to redefine that relationship, and these initiatives are beginning to reconceptualize what it all should look like. Caregiver stress is often conceptualized as a result of the needs of the care recipient, but again, that's not necessarily always the case. So stakeholders observe that caregiver is actually derived from the personal characteristics and capacity of the caregiver. So thinking beyond just the formal non-systems, but what is their education, what is their income level, what language do they speak, and what's their culture, because all of those are going to impact on their ability to care and manage the system as well. So the challenges inherent in attempting to access needed informal services in these fragmented and stretched non-systems. When caregivers are no longer able to manage as a result, what do? They turn to the default options, which are not really ideal for the caregivers because they don't want to revert to that. It's not ideal for the care recipient because they don't want to revert to that, and it's definitely not ideal for the system. So we can see the effects happening at multiple levels here. So it's definitely starting to build some form of community capacity by equipping these caregivers, but not only the caregivers, the care coordinators, the providers, the service organizations, with the necessary mechanisms to keep these people in the right place with the appropriate care. And we do have one of our reports that we conducted for the seniors project up online on the Alzheimer's website, so that's a direct link to that. So what's next? Yes.
These slides will be available? Okay, so...
They're online as we speak, and people can watch them again.
Perfect.
But people also ask me if it's okay to send them just the slides or a PDF of them.
No, I just I saw people starting to write down stuff, and that's a tough URL to write down, so it'll be available.
Absolutely. So where do we go from here? It's definitely a really excellent starting place, but I don't think we're still not quite there. There's still some gaps. And this is kind of where my dissertation is headed, in this direction. So these initiatives are shifting our thinking, but often what we see happen with the simple one-off solutions is that rather than redirecting the focus from the individual clients, we're just redirecting the focus to the informal caregiver. So we're still keeping a really individualized approach to care. So we're suggesting that what we need to do is start to complicate this a little bit. One-off solutions, individualized focus solutions are not the answer. It's a complex network of individuals that really need to work together to start to sort out what supports we need at the right time, the right place, etc. So we start to use informal caregiver essentially as a political window for change, to start to move beyond that typical medical model approach to care. So begin to transform the one-off interventions, like for just as an example, a tax credit, that support the individual but essentially ignore that there's context around that. This is not just a solution for informal caregivers, it definitely provides support for the broader healthcare systems. So essentially I'm attempting to do just that, get a better understanding of what supports might work best for which caregivers and their networks in what situations. And how do we engage people in a dynamic process to actually produce an initiative essentially that will better support not only informal caregivers, their cared for people, their care coordinators, providers, organizations, and the broader healthcare system at large. So adapting our system to meet the needs of our networks, informal and formal, by expanding beyond what the traditional unit of care may look like, not just individuals, not just body parts, to social networks that are enmeshed in a complex social and formal circle. So just to wrap up everything we've said today in 3 slides or less, basically we've identified informal caregivers are important. That's a really hard argument, or a really not hard to argue. Everyone essentially agrees that that is the case. They provide the bulk of the care in the home and community care context, particularly as key policy priorities like the interest in the ERALC and the acute care essentially being transferred into the home care setting, are increasingly shifting this demand to the home and community care sector, but few resources in terms of economic resources are actually following this increased demand. So we're essentially putting increased pressures not only on the home and community care sector, but on informal caregivers as well. Informal caregiving is in decline, likely as a result of not only the demographic shifts, but also due to the tough physical, mental, and economic costs associated with caregiving, and the extreme stress caused by the fragmented formal non-systems. It's becoming increasingly evident that we can no longer develop policies that assumes informal caregivers will be there to pick up where the system falls short, particularly when we consider the shifting trends, like the formal system increasingly relying on home and community care to provide that heavy acute care, and with minimal resources following that demand, and even fewer resources available to provide that care that's actually necessary to support them and sustain them in that role, particularly when we start to consider IADL supports. So, recognizing this, policymakers are responding with various supports. So it's not all bad. However, it's been a relatively slow process, as Paul mentioned. The one in Ontario it's still not even out, and it's been an ongoing thing for about, I think, 3 years now. So it's been a slow process, and there is essentially an overall lack of consistency about how this all actually should work and what it should look like, and a lack of evaluations as essentially a result of that. So even still, the approaches that are out there right now, for the most part, are still those one-off, individualized supports. And that's what we're saying. We need to start to push that. And we can start to push that. We need to start to recognize that health and healthcare are not separate from the social context. And underneath health of the formal care systems is essentially inherently tied to the health of our informal networks. So without our health of our informal networks, we don't have a formal network of support either. So we need to start to consider more than just the individual, more than just the hips, eyes, knees. Start to consider networks of care and how our formal system is essentially heavily related or relying on those networks of care. And it's a tough thing, it's complicated, it's messy, it brings up challenging debates like who does what, are we sure we're okay to pay for that? What if they take this and they spend it on alcohol? Where do we build that trust, that accountability mechanism in there? It's not a pretty picture, so it's tough to make that change. But caregivers definitely give us that opening to start to push our thinking, start to push reconceptualizing our healthcare system as a whole, to see, can we actually change the way our system is providing care from the medical to more acknowledging that that context is essentially crucial to the sustainability of our system. Do you have anything to add?
Yeah, the final slide.
There's another one?
Yeah, Allie, Peckham.
Talk to me.
That's right.
So thank you all for coming and listening to my very passionate topic. If you guys have any questions that you want off the record or what have you, feel free to email me. I'm always willing to engage in discussions like this.
But there may be some on the record right now.
Yeah, absolutely.
People have questions?
We'll at some time have to have an insurance policy in order to pay for a personal care worker. I mean, what do you do as a person to plan for your aging?
Well,
Build in a
well,
suite.
Quebec tried
Will
this.
become my care worker suite in the basement, so I can have somebody live in and get free to take care of me. I mean, I don't know.
See, it's interesting. Claude Castonguay in Quebec, who was the father of Quebec's Medicare system, actually floated this a few years ago in Quebec, which is not bad in Canada for providing a whole series of systems. And it was shot down as not sounding right. But I don't know. You see, I don't know how to answer that question because I don't think it should be getting to that. You see, the problem is not you if you can afford it. The problem is the guy next to you can't afford it, okay? And that next guy is coming back to the emergency department. So I think we've got a liability there anyhow, right? So I think it's probably cheaper to make sure that you have some minimal amount of service than to wait until you need a maximum amount of service someplace which is bad for everyone. So you see, that's the trick. And the problem is, you're gonna die anyways, right? Was this a waste of money? That's the tough.
The argument, and I've had this with friends, is would you rather be fit and have your mind go, or have your mind go and be physically in need of it? Sometimes.
Oh my, that's an interesting trade-off. Let me think.
Like really, because they don't usually go hand in hand. I can see, if you have a stroke, if you're paralyzed, you are now going to be able to cope. And only if you have home care coming to the home. If you have Alzheimer's and you can't mentally cope, then you have to have a full-time supervision.
No, sorry, you don't. It depends what kind of Alzheimer's. So again, my mother is, I don't know, she's pretty advanced. She's a 5 on that scale. She's fine. She can.
Yeah, and you're right. Things don't usually happen all together. There's an increasing need because of either age or debility.
Yeah, but the point I was trying to make is that, you see, she goes to a day program. She's socialized. There's people who see her. A lot of stuff is going on there, but it's really sort of simple. And I have to say, I think that a lot of the simple things work really well. I mean, I don't know, have people been to Alzheimer's Day programs?
Yeah, they're great.
The people there are off the Richter scale. This isn't sort of, I forget what day it is. They are up to the point of actually having aggressive behaviors. But I'll tell you what, you should go to them. Just amazing what they can do by having people in a normalized situation. And then they take them back and their caregivers can take care of them because they didn't have to do it 24 hours that day. So I agree with you, but it's sort of, you're asking, do I need insurance to have the person for me? You see, I'm looking at it from a system point of view, saying it wouldn't be such a bad idea as a system. Like if you can't afford it, what happens then?
Yeah.
You're going to default back into the most expensive part of the system anyways. So I don't sort of want to answer your question. I prefer to have a system which can ratchet up when it needs to. Supportive housing is another. So I have a mother-in-law. My mother's got it. This woman is like worse, but she lives in supportive housing in Yihong. Okay. So you know what they do there? I mean, they're all off the Richter scale. Every one of those people could be in long-term care. When they don't see her for 24 hours, the old ladies go and find her. When she doesn't go to Tai Chi, they go find her. After Tai Chi, they have lunch. They see if Mrs. Lum's looking okay today. Okay, that's what kind of early warning system they've got going there. So instead of doing a full-scale assessment, I mean, the old lady next to them is doing the assessment. So you see, I think that we tend to think in terms of, I need all this stuff, but in actual day-to-day life, a lot of stuff happens sort of normally, and it would be better if we figure out ways of doing that. Like supportive housing is brilliant, eh? Yeah. Everybody been to supportive housing? Well, the only difference in supportive housing is you know you're going to get what you need when you need it. So the Alzheimer's ones are unbelievable. They all could be in long-term care, but they just manage by bringing them to lunch and seeing if things are available. And also they have very good relations with the people outside, because quite frankly some people go wandering from time to time, and then the police officers have to go find them, but they keep track of that as much as possible. They really they monitor in a very funny way. You see, I think part of this is also in Yihong is ethnocultural, because you come from a society where there's been a lot more sort of surveillance. All right, to be blunt. Also in the apartments they have these motion detectors, and if that thing doesn't trip in 24 hours, they go find out why.
And we're not arguing that long-term care is not necessary. We're just arguing that often inappropriate care is provided in inappropriate locations, right? So it's just like meeting those appropriate needs.
Based on that, it puzzles me that more funding hasn't gone into creating more such places. And it's been years and years and years and years and years we do this. And we've actually got proof that it works well.
Yeah. Well, if
and
they
yet
want
why
to see stats,
doesn't the
right? They're
government
numbers driven.
follow up with, okay, if this is working better, why aren't we putting funding to it? Blows my mind.
It was such a great idea, why don't we do it?
Why don't we put more funding in it? There's funding for in places like the supportive housing, with particularly a focus on Alzheimer patients or early Alzheimer patients. Dementia generally. Yeah.
Well, no, but it could be dementia, but also it could be all sorts of physical disabilities. In fact, there's a couple of places downtown, Senior Link, or it's now called Neighborhood Link. They actually pick up street people.
Yeah, it needs to be more affordable supportive housing. There isn't a lot, the wait lists are too long. A lot of people are stuck choosing long-term care because there isn't enough of that IADL support that's being renewed. There's a lot of focus on ADL needs. Well, I'm not incontinent, I could bathe myself, but I can't get a personal support worker to help me with meal prep. I can't afford meals on this.
A brilliant example. So you're familiar with people with mental health issues. So LOFT, which is supportive housing for people, leap of faith together. Deals with, they support people with very, very high-end mental health issues, and they do it very, very successfully. But there's one LOFT.
Exactly, and then
What do you think the holdup is then? If these places are wonderful, what do you think the reason is?
You need to clone them.
No, you need to clone them, but okay, so why is it that we keep throwing all the money into hospitals and doctor services? Ask yourself that. Okay, let's get cynical for a second. And we know a lot of very good hospitals and a lot of excellent doctors and everything else, and everybody says it's not me. Okay, but look, I mean, what would happen if you tried to close some hospital beds? Well, you dump a lot of registered nurses on the street, and then they have to go work in the community where the wages are half. There are some issues here, stuff that used to be done by paid professionals in hospital settings, which are extremely well resourced, are now being done by the working poor, the PSWs. Okay, so it's not, there's a bunch of stuff going on here, but look, I mean, when you shut hospital beds, particularly in a small community, you throw a lot of people out of work too, right? And doctors don't like it because they lose their, so there's a lot of embedded interests. It's very difficult to shift healthcare systems, and the Brits know this as much as anyone else. And you've got a very powerful government there that can come in any day of the week and say, do this. Not like Canada. Okay? They can say, do it, because they own the hospitals and they own half the docks. Right? We can't do that. In Ontario, our hospitals are still run by private independent boards, although they're not for profit. And the docs are all independent entrepreneurs. So go tell them to do that. And this isn't that they're mean. It's just there's an invested interest here. You see, the real question is where you, in a system that's so embedded, how you get a window of opportunity. And that was the last slide there. I think mobilize the care. You see, you can't mobilize people with Alzheimer's. That's not good. Health professionals try this, but of course, you know the story about this invested interest. It's like telling us in the university that we have to listen. We don't like it either. But you see, I'm a caregiver. I'm happy to mobilize. I don't think this is working very well. I think that my kids better, I don't know, well, maybe they're just going to throw away the key. But I really do see, the question is, the policy literature says once you're on a trajectory and you've built all these institutions, you've got everything moving, very difficult to turn the bow of the ship. And all the European countries, which are 10 years, 15 years ahead of us in terms of the aging population, which are also very good in terms of a lot of things, still they got the same sort of issues. So the question is, what pushes you off? Is it crisis? I see crisis goes two ways. One is you improve the system, the other one is you let it blow out. And we just do the American thing. You can afford it, you buy it, you can't afford it, too bad. Which is pretty much what happens outside of the hospital doors, by the way. Except that in the US, well, we don't know what happens to them. Here, they go back to the hospital, because that's where we queue you.
I got the implication that from your talk that if the system, they don't have a personal care worker system, a support system from family or friends or whatever, then they have to go to some kind of long-term care. And it sounded as if you
or the hospital emergency department.
Or hospital emergency. But say we're in a situation where this is not a short-term care issue, you know, which would be the hospital. You need something long-term. What does it cost? I mean, I know my mother in the retirement home, and those are very expensive. But what about for people who have no money? What are those? What are those alternatives? If somebody does not have the family support system, you can't stay in a hospital forever. They have often, many of the hospitals have a continuing care wing or whatever, and there are waiting lists, so like years-long waiting lists for those. But what do people do who do not have any particular money other than their government pensions, which is not an awful lot?
They default. They default to someplace. They default. Okay, so we know the relative cost of things. An acute care hospital bed in Toronto is about $800 a day. An ALC bed in Toronto is about $400 or $500 a day. Think of what you could do with $400 or $500 a day. A long-term care bed in Ontario is about $140 a day. About 80 of it, 85 of it comes from the government, and you pay the rest if you can afford to pay the rest. Okay, because there's a sliding scale there. You can go and CCAC, if you get services to them, totally free.
Yeah.
Don't pay anything, but you just can't get them.
So who's that? Which organization?
Community Care Access Centers.
Community Care Access Centers.
Yeah.
CAC.
Okay, so they are government funded. There's no cost to you if you can get the service. But the point is that fewer people, unless you're very high levels of acuity, are getting them. And then when you go to community service agencies, well, it depends. Most of them have a sliding scale, but now you have a cost. So there's a real disincentive against using their services. So it costs my mother, if you can imagine this, $15 a day. To go at $15, like that's not even 2 drinks. No, but let's put this in perspective. But $15 is actually enough to deter many people from using that. The hospital emergency ward is for free. So what have you done here? You've set up an incentive to use the most expensive, inappropriate place in the system, or to wait until it gets that bad.
What do you get for $15 a day? What does that provide?
Well, I take her there. She gets activation. They do all sorts of stuff, puzzles and bingo and stuff. She gets lunch, really great lunch. It's cooked.
Does she go there every day? Is that an every day?
No, because I have to get her there. Unfortunately, the wait lists for these things in Toronto are very, so I have to go out of district. So the only way I can get her there is I have to drive her. So it takes. Yeah, okay. Well, but I have a car and I've got a job where I can say I'm not coming in, right?
Right.
And then another day, we had her at a different place, and then she got, I have to say, it's like kindergarten, because they said, your mother's acting up. Oh, I go, what's she doing? Oh, well, she's telling the other people to walk faster. I go, that's funny. And so, why don't you just put her beside a deaf person? And they wouldn't do that, so she got booted, right? Like I swear. Because,
she got booted out?
Yeah, she got booted out. She's Italian, eh? So she thinks it's normal to talk like this. So she's at a place right now with Italians and Portuguese, and they all talk like that. Go faster. Okay, she went to the Anglo-Saxon place, and they didn't have such a sense of humor. Anyway, she got booted.
Thank you both for excellent presentations and research. If I can mention a couple of things after 7 years of informal caregiving and formal caregiving experience and continuing. Alzheimer's Society, Alzheimer's Toronto was fantastic.
Yep.
The very best advice we got, I brought my mother up from Vancouver. It was 2.5 years of immigration paperwork. Now I think it's worse, longer. Someone in her retirement residence, I was live out caregiver for her. She went right into a retirement residence. She was always an apartment dweller. Best advice was early on, as soon as she moved up, to get her on the CCAC list when she was still walking, when she was still walking and verbal, authorized by her doctor that she would be on the waiting list, because when she needed it, a year and a half later when she fell in that home through unfortunate negligence and fractured her pelvis and was in Bridgepoint rehab, she only spent 2 months extra in rehab before Kensington Gardens opened up for her, so it was a year and a half waiting list for her to get in there, and it was exactly the point that she needed it, or 2 months earlier. And there's a huge difference to the caregiver between live-in and live-out caregiving, as I'm learning when it goes from my mother to my spouse to my husband, which is starting mild MCI, cognitive impairment, and it's a huge difference for the caregiver and for the family when live-in versus live-out care. And in terms of stress, in terms of vigilance, in terms of everything. But your research is excellent. Thank you so much for doing it.
Thank you.
It's really important.
By the way, now, if you phone up the CCAC and you say, I want to get my mother on, and she can do the things you said that your mother
Oh,
can.
you do it through a doctor?
No, just a second. She will be triaged out.
As a change, this was
Yes.
Yes.
That's the point. That's the point. It used to be at a lower level of need, you could get in. Now you will be triaged out and told to come back when it
It's
gets worse.
further perpetuating the after the fact care versus the before the fact care. Yeah.
Those are the numbers I showed you where it's all going to post-acute care?
Yeah. That's
So it would
exactly
have been after she had her
Yes.
fall.
Correct. Indeed.
Now she's
So that
eligible.
you would.
Sorry.
But I think it's kind of,
I just want to thank the speakers before everyone. And I did have a couple of questions from these guys, if you care to answer them. Jill asked about the new policy in Ontario for unpaid leave. Is that for dementia only?
I don't believe so.
Bernie?
well, the legislation hasn't passed. We don't have regulations, so we don't know.
Okay.
So the legislation will authorize the government to do something, but it'll still have regulations about who's actually eligible and how this works.
The other couple of things are more like comments from Marguerite.
Great.
She said what really makes me crazy about caring for 2 older adults is the specialists on the staff that assume that I sit on the couch all day eating bonbons and just waiting for them to call so I can drive them, one of my loved ones, many kilometers to suit their schedule. My best story is where she was expected to be in 2 places at once, and she also has a job, and she's got a life and kids, grandkids and great-grandkids, and now and then she does like to sit on the couch.
Yeah, no kidding.
She was also asking about financial stuff. She's saying that she learned a lot when she was moving her mom from a retirement home to long-term care, and that they didn't know that she would have only 24 hours notice to make up her mind about moving, but was required to pay 30 days notice at the retirement home. So, which basically money for nothing. So we also learned that all the financial institutions required notarized powers of attorney for a change of address, and that our lawyer did not advise us about that. So is there any booklet on these financial issues to forewarn caregivers? And she just gets slapped down right, left, and center.
That's a tough one.
I did tell her about the NICE tools that have some things about financial literacy, and she checked them out, but she said it's mostly information for the client, not for the caregiver.
Actually, St. Elizabeth has really started a nice new webpage for strictly focusing on the informal caregiver. Really fascinating. So I know that they're really starting to build up their resources and information sharing, etc. And the
Advocacy Center for the Elderly.
that's one, and there's another one. Oh, I can't think of it right now. Let me think. It'll come to me. Yeah, typical.
So St. Elizabeth.
St. Elizabeth.
St. Elizabeth, yeah. They have a really nice new
And Alzheimer's also.
website.
Alzheimer's very good.
Yeah, totally.
And Alzheimer's, that's a good idea. That may not have been part of her needs, but good.
It's complicated.
But even still, they have really good resources just for how to manage, right?
Right.
So, information sharing is good.
Are we ready to?
Sure, if you are, yeah.
Thank you.
Thank you.